So we're going to focus on a case-based approach to cardiothoracic surgical complications. And a lot of that is going to rely upon not just the imaging findings, but really an understanding of the surgical procedures and some of the techniques involved. So when it comes to complications, a generic definition here, maybe it's not so generic, but the American College of Surgeons actually weighs in on this. But they'll say an unexpected surgical or postoperative event that causes morbidity or mortality. And so you could have something unexpected that doesn't really have any impact on the patient, and it wouldn't necessarily be considered a complication. But these can then be subdivided into either avoidable or unavoidable. And you can imagine unavoidable complications could be due to, well, the patient has much higher risk for the procedure, inherent to the nature of the surgery. This is perhaps unavoidable, or it's an expected complication as we go through. Avoidable complications are those that may be due to physician error, so iatrogenic causes, or some other things that just were out of the ordinary for the course of care. Now, complications can be a diagnostic challenge. For radiologists, I don't know about your practice, but we don't really get a lot of clinical information. We may have a CT that comes through and it'll just say chest pain. Or even diving into the medical record, sometimes there's not a clinic note available, and so you then have to make a phone call. But having as much clinical information is important because it can certainly change your differential and even the diagnosis as we look at the images. And important findings can often be subtle. You open up this post-surgical CT and they can be just an absolute mess. And more often than not, maybe the finding is going to be obvious, but sometimes it's very subtle, and the post-surgical anatomy can be complicated. And in that setting, it's hard to know what's a complication versus what is just kind of the expected outcome of the surgical procedure. And here we have an image here. So is this a complication? We've got some pneumopericardium, there's some fluids and perhaps blood products in the pericardial space. And the question is, well, is this a complication? Well, it really depends. So if they are one-day post-aortic valve replacement, and even this is a little bit extreme, but you may chalk it up and say, you know what, based on the nature of the procedure and what was involved, perhaps this is not a complication. Whereas if they're 6 weeks post-pulmonary vein ablation, then yes, this is going to be a complication. This would not be the expected course in this type of procedure. And so clinical information is important in our interpretation. Now, there are some complications which, again, are common irrespective of the type of surgery. And I tend to think of these as the things that you consent for in the procedure. So bleeding, infection, injury to adjacent structures. These are inherently risk in all types of surgeries. But then you have some very surgery-specific complications. And as we go through some cases today, we'll talk about some of those nuances. So our first case is a 56-year-old woman who is post a left lower lobe VATS wedge resection. Here's the CT, the chest radiograph, and this is what she looked like. She had been doing great, and here we have chest tube removal. And now there is an opacity and a collection here. And a few hours later, the chest x-ray was repeated, and this is what it looks like. And I've provided some clinical information. Her hemoglobin has been rapidly decreasing. We now have complete opacification of the left hemithorax. There's mediastinal shift to the contralateral side. And so whatever this process is, it's rapidly increasing. So here's the CT. Hounsfield units is your friend. In this particular case, 58 Hounsfield units in some of those higher areas. The CT really correlates with what we saw in the chest radiograph. And this is diagnostic of a hemothorax. Now, bleeding is, again, not an uncommon complication post-operatively, but it only occurs in a small percentage of cardiothoracic surgeries. Venous bleeding is typically not going to be very problematic. It's self-limited. It usually won't prompt imaging, whereas arterial bleeding can be problematic and often requires intervention. And when it comes to thoracic surgery, although I saw that the intercostal artery, which was the culprit in the case I just showed you. In the literature, the most common artery that's causing significant bleeding is the bronchial artery. And the reason for this is post-thoracic surgery, so whether it's a VATS, whether it's a lobectomy, the bronchial arteries, even if very, very small, they're under much higher pressure than the pulmonary arterial system. And so even very, very small bleeds often won't stop on their own, whereas a pulmonary artery is often going to be self-limited as well if it's one of the smaller branches. And so again, from the data, the literature says that the bronchial artery is the most common culprit for hemorrhage post-thoracic surgery. Well, what are some signs of active bleeding? Well, hemodynamic instability. So the patient's not doing well, their crit is dropping, their pressure's dropping. Bloody chest tube output is a common indicator. Now, it's not uncommon to have some blood in the chest tube after surgery, but it's usually not going to be prolific. So more than 1,500 cc's a day, you can imagine, that's going to be a concerning sign. Or if you have active bleeding more than 200 cc's an hour for more than 2 hours, that this is a sign of active bleeding and that the patient, it's going to need to be addressed. Chest x-ray can often raise the concern, as we saw in our case, rapid accumulation of something in the pleural space. And CT is often diagnostic, but unfortunately, it rarely is going to identify what the source is. Even if you see kind of blushes of contrast, it can be suggestive of where the bleed may be arising, but sometimes they'll have to go to conventional angiography to identify the bleed and be treated with embolization techniques, or in some instances, back to the operating room for definitive treatment. This is a different patient. So we have this high attenuation pleural collection. You can see it's really extending around the aorta. We didn't really identify where the bleed was coming from, but this was new, and the presumption was that this was associated with a rupturing aneurysm, which turned out to be the case intraoperatively. Next case, we have a 61-year-old male post-op day 5 from a right upper lobe segmentectomy for non-small cell lung cancer. And on the chest radiograph, one of the findings here is we have this kind of lucent area external to the chest, or the rib cage. So it's in the subcutaneous tissues of the chest wall. There's a chest tube in that area, and you can certainly have air that will leak out around the tube. You can get subcutaneous emphysema, but this is pretty discrete. It's isolated in that one area, and it's pretty characteristic of an intercostal hernia of lung. This is what it looked like on a coronal reconstruction. You can see the collection of lung that is external to the rib cage, and that kind of narrow waist denoted by the blue arrowheads where things are kind of getting constricted. It's important to kind of evaluate what that lung hernia looks like. It's not uncommon for there to be some venous congestion associated with it. And even with venous congestion, they're often asymptomatic. But if a patient develops symptoms associated with a lung hernia, and if there's findings on CT that may suggest vascular compromise, then those are indications for treatment. This is a different patient, which again shows a hernia. You can see the increased kind of venous lines there, the septal thickening. Again, this was congestion. And I'll show you a case in a little bit that was a little bit worse. So in general, lung hernias, they're not entirely uncommon, but you have protrusion of the lung with the pleural membranes through a chest wall defect. The intercostal space is most common. It's usually associated with a trocar site, or if they did an open thoracotomy, or sometimes, rarely, you can see it post-chest tube removal. One of the things that you can look for clinically is paradoxical motion with respiration. And I have a video, which unfortunately I can't play on the PDF, but clinically you can have a patient take a deep breath in and then breathe out. And when they breathe out, you'll actually see the kind of protrusion of the lung hernia. Oftentimes, patients will have pain, focal pain at the site. It's usually thought to be more associated with the intercostal defect than the hernia itself, but pain is an indication that you may need to treat. And there's often a risk of strangulation with ischemia or infarct of the lung. And surgery is performed, again, if they're symptomatic or often if they're large. Here's another patient where we can see the hernia on the chest radiograph as well as the CT. There was a bit more kind of ground glass opacity in this hernia than we would perhaps like to see. Because the patient had significant pain at that site, this was treated, and intraoperatively they said that the herniated segment appeared infarcted. Next case is a 53-year-old woman post-CABG. Here's the pre-op film. And here's post-op, and so we obviously have the sternotomy wires, but the finding of note here is the elevation of the right hemidiaphragm. Now in the immediate post-operative period, it's not uncommon for there to be a component of diaphragmatic paralysis, and so you can actually see in the post-operative period that the diaphragm is elevated. Sometimes this is due to diaphragmatic nerve injury associated with the cold water bath or the ice bath that they put around the heart during cardiac surgery. And this will often kind of improve on its own over the course of several days. However, in some instances, it will actually persist or even progress and result in pulmonary compromise. You can see there's some atelectasis associated with this patient. Here's CT. This was taken a few weeks later. It had not improved. In fact, it had slightly worsened. So what types of nerve injury are associated with thoracic surgery? Well, the phrenic nerve is one of the most common involved. You can have vagus nerve injury. The recurrent laryngeal nerve is at higher risk in certain procedures, such as esophagectomy. And the intercostal nerves are another common set of nerves that can be injured and result in clinical symptoms. Phrenic nerve injury, it's variable in the literature. Upwards of 10% of patients will have some degree of phrenic nerve injury. Fortunately, in most instances, it's not permanent. Specifically, cardiac surgery has the overall highest incidence of phrenic nerve injury. And the left phrenic nerve is often more commonly injured than the right, although the case I show here is on the right. And that has to do with a more complicated course of the phrenic nerve on the left, as well as, again, just the nature of surgery, the location of the heart being more leftward oriented. Phrenic nerves can be injured by compression. So you can imagine you have a retractor that may be compressing the nerve. You could cut or transect the nerve. Pulling or traction on the nerve itself could result in injury. And then hypothermia, as I previously mentioned, is a common cause, but is often reversible. Again, this is a video, but I can't play it for you. I apologize. But if you really want to confirm phrenic nerve injury or paralysis, then perform dynamic fluoroscopy, where again you'll see paradoxical motion. So with inspiration, the normal lung will drop, the diaphragm will drop, whereas the abnormal lung will actually rise. Our next case is a 65-year-old woman with dyspnea and a 40-pack year smoking history. And so here's the CT, which led to a PET, pretty characteristic findings, a FDG nodule. So she had, unfortunately, an early stage lung cancer. And she went on to have a lingular sparing left upper lobectomy. This is post-op day 1. So we see the left chest tube in place. We have some subcutaneous air in the chest wall. But we note this kind of opacity here. Again, not entirely uncommon post-thoracic surgery. Some of this is going to be atelectasis. There's going to be a surgical staple line in that area with a lingular sparing left upper lobectomy. On post-op day 3, we now see a shift. So this area of opacity has now shifted more into the mid and lower aspect of the hemithorax. And this is concerning. This is one of the early indicators that the lung may actually be torsing. Now, it's not uncommon post-thoracic surgery, particularly related to the lung, for there to be some kind of shift or reorganization of the lobes. They may shift in some orientation, but this is a bit dramatic. And we actually called the surgeons and said, you know what, we're concerned that this patient may be having a pulmonary torsion. And they're like, nope, the patient's doing fine. We're not concerned at all. Here's post-op day 5. And even more consolidated, you can see they've taken the chest tube out, and they said, no, the patient's doing fine clinically. But we were concerned, and so we recommended a CT. They eventually got a CT. This is a MIPS image here, and I performed the MIPS just so you could see. The red arrow is designating the staple line, and so that is the lingula. The lingula is now completely consolidated, and the lower lobe is now very anterior. So we were again concerned about torsion. Unfortunately, again, this is a video, but you can't see it play. But what this shows is this kind of spiraling effect of the central pulmonary arteries. So in a normal pulmonary artery, it just kind of drapes. It's kind of takes an oblique course with kind of branching. But with torsion around the vascular pedicle, you get this spiraling effect of the vessels. And again, you can kind of see it here. This is a normal appearance pre-op. It just kind of will kind of branch as it moves down, whereas post-op, this was all completely twisted up. And this was the actual lingula, which had now moved posteriorly. So we were fairly confident in torsion. I spoke to the surgeon. They took the patient back to the operating room. And interestingly, in their op note, they never mentioned torsion at all. They just said that the lung looked a bit dusky, and they kind of like plumped it up or manipulated it, and poof, and now it looked great. So I spoke to the fellow, and they're like, oh yeah, that was totally torsed. And so anyway, but beautiful case of torsion. So torsion is technically a 180-degree rotation around the pedicle, vascular pedicle, but also the airway itself. Post-surgical is most common. We see it lobectomy as well as post-transplantation, although, as we saw here, you can also have it with just a segmentectomy. This was a lingular sparing case. Pneumothorax, so you have a large pneumothorax and the lung collapse down as it starts to re-expand. It could torse. And then trauma is another cause of torsion. Now, that case illustrated really most of the findings that we associate with torsion on X-ray. So you can see abrupt cutoff of an airway, opacification of a portion of lung after surgery, collapsed lobe in an unexpected location, tapering of the airways or vessels on CT, displacement of the fissures, the rotation of the airways and vessels, and the diseased or torsed lobe will often have ground glass opacities or even infarct. This is a separate case. This is a patient post-bilateral lung transplantation. And the red arrow is actually the superior segment of the left lower lobe, and it just was completely kind of tapered. It wasn't an abrupt cutoff like you'd see with mucus plugging, but it had tapered until it was obliterated. And then the yellow area designates the superior segment. And you can see it has reduced volume. There's ground glass opacities, and we were concerned that this was on its way to infarcting. And so in this particular case, post-transplant, that portion of the lung had become torsed, compromising both the airway as well as the vessels. Here's the sagittal reconstruction. This is the major fissure. Now, even a medical student knows that's not the proper orientation of the fissure. So this patient went back to the OR. In this case, they actually did document that they thought it was torsed. They kind of detorsed. The literature says detorsed, but you don't find that in the dictionary. But post-detorsion, this is what it looked like. And so the orientation of that major fissure was, again, anatomic, and the opacities and the lung abnormalities had resolved. Unfortunately, they didn't lose any portion of that transplanted lung. All right, case number 5. This is a 53-year-old woman post right lower lobectomy for non-small cell lung cancer, and she'd had progressive white count and fever. So you're worried about some sort of infection. Here she is post-op day 2. Again, we've got some atelectasis, a little elevation of the right hemidiaphragm. The chest tube is in place. On post-op day 8, we have a few findings. We have a new air fluid level, or perhaps a more prominent air fluid level within the right lung base. The chest tube is now out. And in the left lung base, we have these more heterogeneous airspace opacities that you may be concerned about aspiration or infection in this particular case. So the patient went on to CT. As I mentioned, they were post right lower lobectomy, and now we see bilaterally. There's these ground glass heterogeneous opacities. Some of this could be edema. There's certainly maybe a component of atelectasis, but you'd still be concerned of a multifocal infectious process or even aspiration. What the arrow is highlighting is a defect in the airway that is communicating with a larger air collection. And again, knowing the type of surgery the patient had is important because on the CT, often when I see this, and I'll show you a companion case in a little bit, it looks like maybe the patient's had an esophagectomy and this is a gastric conduit. But in this particular case, it was the pleural space. There was just some pleural thickening. There was fluid in the pleural space. And this represents a dehiscence or a defect at the lobectomy stump. On the soft tissue images, you can actually see some of the suture or staple material there, and again, that defect. So this was a bronchopleural fistula from the lobectomy site. Now, BP fistulas, again, it's a communication between the airway and the pleural space. And an air leak can develop due to failure of the staple or suture line. And we can see BP fistulas occur even with VATS and wedge resections, or with lobectomies, or with pneumonectomies, although in that case they don't really have a pleural space anymore, but it can still result in similar findings. For lung transplantation, they'll have a prolonged air leak that we'll see clinically, and it's due to anastomotic failure of the transplanted lung. BP fistulas can be central or peripheral. This is somewhat of a both anatomic as well as an academic classification. So central fistulas can involve the mainstem or lobar bronchi. And again, these are some of the stats around these. So with lobectomy, it has a pretty low incidence, whereas with transplantation, up to 10% of patients can develop a central bronchopleural fistula as a result. Peripheral BP fistulas involve the segmental or subsegmental airways, and these are often self-limited. So even if you see them, they may not require intervention and they can resolve independently. Whereas the central ones, you're looking at perhaps a need for additional surgery, often some sort of muscle flap repair in order to treat that BP fistula. On chest x-ray, you see persistent or enlarging pneumothorax or hydropneumothorax, and often there's going to be a lack of mediastinal shift. So normally when you resect a portion of the lung, there's going to be compensatory hyperexpansion of the residual portion of that lung, and even a component of mediastinal shift to compensate for the loss of volume, which you won't necessarily see with an ongoing air leak or bronchopleural fistula. On CT, you can see directly visualize the fistula. The older literature says you rarely see it. In some of the newer literature, it's more commonly identified. Again, I think that just reflects the transition from, we used to only get 5 millimeter cuts, and now we're getting like 0.625 millimeter cuts. And so oftentimes you can find it. The central ones are obviously much easier to identify than the peripheral. Patients are at increased risk for aspiration because you have a communication with this collection which may become infected directly with the airway. And so you can get an empyema, and then they end up refluxing into the airways. It becomes more widely disseminated throughout the lung, as we saw in the case I showed earlier. Case number 6 is a 56-year-old man post-McKeown esophagectomy with gastric conduit, and had chest pain and was unable to eat. Now, esophagectomies in general, I mean, they can be fraught with all kinds of complications. In this particular case, the gastric conduit is this thing right here. So here's the lumen of it. This is the wall of the stomach, which is edematous. It looks like just a fluid collection. So you have kind of the inner portion, the outer wall, and then you have pleural fluid around it. And so this is a big, thick-walled gastric conduit that is not looking good. And so, in fact, this conduit was completely ischemic and had started to necrose and needed to be removed. When you lose, so the stomach is the preferred conduit for esophagectomy. But if you lose the conduit, then you have limited options. And so you may end up with a colonic interposition as the treatment for this. So fortunately, it's pretty rare. Ischemia is the most common cause, particularly early on, but infection can actually lead to ischemia as a later complication. And as we see here, you have wall thickening out of proportion to the luminal distension. And if you give contrast, you'll see a lack of contrast enhancement within the conduit. Now again, because a knowledge of the surgery is important, with esophagectomy, there's two primary procedures performed in the States. There's the Ivor Lewis, which basically is used for middle to distal third esophageal tumors. It's a laparotomy as well as a thoracotomy, and it's going to result in a thoracic anastomosis. So you'll see the anastomosis somewhere kind of the carina region. Whereas the McKeown, it's usually reserved for upper third esophageal tumors, and it requires not only a laparotomy and a thoracotomy, but there's also a neck incision. And often on the chest x-ray postoperatively, you'll see that neck incision near the apex with some staples associated with it. And that's kind of the visual clue that they've had a McKeown. And so they frequently will have an upper third anastomosis. The complications associated with esophagectomy are numerous. You can have anastomotic leaks, strictures, ischemia, herniation, thoracic duct injury. We don't interpret the upper GIs in our division. They go to our abdominal group. But our thoracic surgeons, one of their complaints is that they overcall leaks. And I know you want to be conservative, but one of the reasons for overcalling is you get incomplete distension of the residual esophagus and the conduit. And so often the rugal folds of the stomach can look like areas of leak. Now, in this case, early on, there's two areas that look suspicious for leaks. You want to keep imaging through the upper GI series. And on these more delayed images, it's confirmed that yes, these are in fact two areas of leaks. On this particular case, the patient, actually the upper GI was called negative. They didn't see anything, but on the delayed image on the chest x-ray, so it's important that you do get a post upper GI series chest x-ray, you can see that there's actually contrast in the chest tube. And that means that there is a leak, even though it wasn't visualized or seen on the upper GI series. So leaks are not uncommon. Again, in the literature, 10 to 50% of patients will develop an anastomotic leak, and that can lead to additional complications such as mediastinitis or loss of the conduit. So you want to make sure that you identify leak early on if possible. This is another patient post-esophagectomy. It was not a bronchopleural fistula, but in fact is a bronchogastric fistula with the conduit. And on the upper GI series, they saw tree and bud contrast, and they thought, well, maybe the patient just aspirated as part of the upper GI series, when in fact, they actually had contrast entering the airway through the bronchogastric fistula rather than, and it then led to filling of the airways and alveoli. All right. Our last case here, 6-year-old man post-esophagectomy with progressive dyspnea. So here's his postoperative chest radiograph, fluid collections, again, not uncommon. You have atelectasis as well, but his chest tube output was pretty significant, more than 1,600 cc's a day, and that was at post-op day 5, and it wasn't relenting. He went on to have a CT lymphangiogram, and it identified not one, but 2 areas of thoracic duct injury that was leading to that high chest tube output. So this is a case of chylothorax. The thoracic duct is ligated as part of transthoracic esophagectomy, but even the ligation can sometimes fail and result in thoracic duct leak. If you don't have a frank leak, so you may not have anything coming out of the chest tube, you can still develop what's called a lymphocele, which will be just an isolated collection of lymph material. And the incidence is about 4% post-esophagectomy. So again, clinically, high chest tube output, send that fluid off. It'll be positive for triglycerides. And so that can be diagnostic from a clinical standpoint. And then CT or MR lymphangiography is helpful to identify where the leak is located. And in fact, now, rather than surgery, they can often do interventional radiology, can try and seal those or close those off. So in conclusion, complications, all right, we see them all the time. It used to be in private practice. One of my co-residents, he went into private practice and he was like, why are you staying in academics? Like, you're just gonna have to deal with all these messes. I'm reading negative PE studies. That was early on. Now he sends me cases, they're just as bad as the ones we see. So private practice is not immune from these complicated post-imaging cases. It's important to be familiar with the surgeries, and I'll just add, it's not on this, but do your best to have a good relationship with your surgeons. That can go a long way in helping you as well as helping them. And with that, I thank you so much for your time. All right.